Yes. Today we have to finish what we started yesterday, and as we finish what we started yesterday, we have to continue with the topic of the day, which is elimination disorders and eating disorders. People that have eating disorders that cause their mental uh, programming to be distorted. Now, I welcome everyone to the platform. This is a medical platform where we talk about mental health and health diversely, everything that affects your health. And as we go on, if someone has any of an issue that you would like to talk about, you are open to come here and uh, and raise it so that we can discuss and see the way forward. Now, I'll go straight to the topic because of time. You know, we have limited time for this discussion. Now, the topic we finished last time's topic, which was management. We did not cover management of insomnias and every topic and subunit that we went through. So we talked about several topics. The first topic that we talked about was insomnia disorder. We went to hypersomnolence disorder, narcolepsy, obstructive sleep apnea, and hypopnea. And we talked about obstructive sleep apnea, hypopnea, central sleep apnea. We talked about sleep related hypoventilation. We talked about cardiac and rhythm sleep wake disorders, which is because of the brain, non-rapid eye movement sleep arousal, nightmares. We talked about nightmares. We talked about rapid eye movement and sleep disorders, and then we talked about restless syndrome. You remember about shaking your legs when you are asleep. Yes, substance and medication induced disorder. That is where alcohol and drug abuse came in. Now, I'll go straight away to discuss the management of insomnia. Insomnia, how can you help someone who is in insomnia? Now, there are two ways of helping a person who has sleep problem, specifically insomnia. One is non-pharmacologic treatment without drugs. You help this person without drugs. And the other one is sleep pattern hygiene, and the other one is pharmacological treatment. Now, health non-pharmacological is this is without drugs. Yeah, this one is a cognitive behavior therapy for insomnia. You try to change your behavior, like stimulus control therapy, strengthening bed sleep association. Go to bed only when sleep. Get out when you feel you want to sleep. You go to bed only when you feel you want to sleep. You see that that is very important. And get out if unable to sleep for 20 minutes. People with insomnia, this is very important. Listen to this. You only get to bed when you feel you want to sleep, but if you are not catching sleep, get out after 20 minutes. It will start jacking your sleep pattern. This is non pharmacological. Sleep restriction therapy. Limit time in bed to increase sleep drive. You limit time that you're spending in bed. If you get home and you are in bed, you limit the time you are spending there. Okay. Cognitive therapy targets negative beliefs about sleep. Very important. Sleep hygiene education. You understand sleep hygiene. Hours of sleep, not prolonged sleep. 8 hours. Very important. These are relaxation techniques like deep breathing, progressive muscle relaxation. The people that do yoga before sleep, very important. You see, that is very important. Now, what someone may ask me, what is sleep hygiene? What is sleep hygiene? This is stick to a regular sleeping schedule. Stick to a regular sleeping schedule. If you want to sleep at 9 up to tomorrow at 7, let that schedule be there. Keep bedroom quiet, dark, and cool, because we talked about the sleep clock that is ignited by darkness. So keep the bedroom quiet and cool, because sometimes when there is noise, sleeping becomes a problem. Exercise during the day. If you don't have something to do, exercise. Bed only for sleep and sex. You see that? Very important. Bed only for sleep and sex. Very important. No, don't go to bed when you don't have a purpose of going to bed. If you want to relax and watch, go to the sitting room, do a sofa. Don't go to bed. There is something called sleep clock pattern that your brain makes. So it will always stick to that pattern. Now, we go to pharmacological treatment. Which drugs can you use to help sleep? And here, this is where we have a problem. Like, there are some people that use drugs when they are not supposed to use them, like benzodiazepine. Yes, they will, the short-term use only, because we don't want to be dependent on these drugs. And you remember, you cannot go to the pharmacy without a prescription of benzodiazepine. So don't try to chase around your doctors to tell them I need this drug, because your doctor knows more than what you know for yourself. Non-benzodiazepines, Z drugs, hypnotic drugs, yeah? Self alternative for short term, like zolpidem, those ones are for short term. Melatonin receptors that helps your brain, especially used for circadian rhythms. Those ones are drugs that use when you have a problem with the circadian rhythm. Those are drugs that you should be given to the doctor. But the most important thing when I'm talking about insomnia, you should have two non-pharmacological: stimulus control, sleep restriction therapy, that one we have talked about, cognitive therapy, and sleep hygiene. When I'm talking about sleep hygiene, I've said stick to regular sleeping pattern. Let the bed be a place where you go to sleep, not where you go and watch movies. You get it? Not where you go and make long phone calls. That one, there is a brain clock that is in you that registers everything. So when you associate your bed with sleep, wherever you go to bed before 20 minutes are out, you will be sleeping. You see? Now we go to another one, hypersomnolence. We talked about hypersomnolence. Now, how can we treat about hypersomnolence? How can we treat hypersomnolence disorder? It's a sleep-wake disorder, excessive daytime sleepiness. You get it? Y- y- you sleep a lot during the day. The risk factors we talked about, it was we talked about genetic infections and viral infection, head traumas. When you have a problem with head trauma, you hit your head, and then there is a problem with neurotransmitters. You get it? This is where we see the difference between hypersomnolence and insomnia. Is, you see, hypersomnolence here is uh, you have sleep every time during the day, but at times in the night it also comes. But in insomnia, you have no sleep at night, or when you want to sleep. That is the difference. So the management will still be the same: sleep hygiene, schedule your naps, cognitive behavior therapy, that like we have talked on on the others, and then we have stimulus, modifilin and amodopilin. First line treatment, modifilin. Your doctor will prescribe this for you. You see, the treatment kind of like are the same, because cognitive therapy and clock patterns, they are always registered in your brain. So those are the kind of treatment that we will always look at when we are a minute. Uh, a minute, yes. When we are looking at sleep disorders, then there is obstructive sleep and apnea hypnopnea. Now, this one is for those people that have this problem. You remember what we talked about, the obstructive sleep disorder today? I started early before because of time. We the obstructive sleep disorder is treatment. The obstructive sleep disorder is kind of a sleep disorder that when a person is sleeping, there is a you are obstructed, and we saw this in people that have obesity, use alcohol, and sometimes smokers because of the airway muscles and large necks. When you sleep and start snoring a lot, this we saw, and I'm not to repeat about the pathophysiology or what happens there. I'll go straight to the treatment. The first thing you should do, we try and lose your weight. Weight loss, very important. Positional therapy. Place your neck wherever is the best place on a pillow that you can sleep without obstructing your neck. Avoid alcohol and sedatives. Sedatives sometimes relaxes the airway muscles and then you start having snoring effect. Avoid sedatives. Very important. Stop smoking. Stop smoking. Reduces airway inflammation and edema. You get upper airway inflammation. When you smoke, your airway reduces in inflammation and edema. So you will start to snore and you will have obstruction. Exercise helps in getting your pharyngeal muscles okay. So when you have a partner or a friend who snores a lot at night, at times it's better to tell this friend of yours that please do what? Please do what? You need to do exercise. Exercise help in snoring sometimes to reduce snoring, and that is obstruction. Snoring is obstruction. Positional airway pressure therapy. That is the ones that I've been talking about is about lifestyle. So positional airway is a therapy helps to continuous positive airway pressure through your nose. Delivers a constant pressure to the nose so that you cannot get an obstruction. And then we have another one called bi-level position airway. Bi-level position airway. Bi-level position airway offers higher pressure during inhalation and low during exhalation. Now, APAP, auto-tating PAP. Those are adjust pressure, adjustable pressure. It's not a big word. PAP is just how to adjust your pressure when you are sleeping. Those are those are the ones that you yourself can do. But you see, there is other ways, like if it is too worse, you are sleeping and you have obstructions around the airway. What can we do? Hmm? When you are sleeping and we have obstructions along the airway, what can we do? You consider in these patients that position airway is not working, no drug is working. What do? We do surgical treatment. There is uvulopharyngoplasty. This thing that is here inside, we remove excess if it is so long surgically. A tonsillectomy, adenectomy. Those are the tonsils and the adenoids. Sometimes they be reduced so that you don't have problems when you are sleeping. Yes, the genital advanced or hyoid suspension. The hyoid is here. It's a bone that sometimes help you not to have a problem. So it's suspended. It is pushed from behind. Those are surgical treatment, and you when at times it's good to treat underlying condition, nasal obstruction, treat allergy or septal deviation. If you have allergies, you better treat them so that you can not be recurrent. Hypothyroidism, the thyroid, if it is big, acromegaly, if it is big, polycystic ovarian syndromes in women. Most women get polycystic ovarian syndromes. If you are a woman and you're getting polycystic ovarian syndrome, please treat it. You get it. Now we continue adjustive therapy, oxygen therapy. You see, if you are having obstructive sleep hypnopia, it is telling us you are not giving your brain enough oxygen. So what do we do? You do what? You get at least something that will reduce it. You get you to reduce the blockage so that you get oxygen in your brain. Adjustive therapies, pharmacological therapy, we have talked about it, them like modifilin, and then your doctor will make a follow up. You see, now we go to central sleep apnea. Central sleep apnea. Now I will let me post them so that when you want uh, to okay, let's continue. Central sleep apnea is we talked about it. We talked about sleep related disorder where breathing repeatedly stop and starts during sleep due to lack of respiratory efforts. You see, breathing repeatedly stops and starts because you don't have the strength to 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 breathe while you are sleeping. So you get it. So there are some things that we can do to these people. We talked about them. You supplement oxygen. You have seen people that are sleeping while they are on oxygen at night, and when they are awake, they don't use it. They're having this problem. And medications, mostly acetazolamine. It's a carbohydrate inhibitor that induces metabolic acidosis to stimulate breathing. So metabolic acidosis, when you have acidic metabolic acidosis, at times it stimulates breathing. So contrary to when you have lactic acidosis that is in diabetic. Now, theophylline, it's a respiratory stimulant. Theophylline, it will make your muscle relax and then the airway will open. Phrenic nerve stimulation. Now, the phrenic nerve is the nerve that helps our diaphragm. Our diaphragm. So, if it is helping our diaphragm, what are we getting when phrenic nerve is helping our diaphragm? We can stimulate it so that breathing continues. Breathing continues. This is done in hospital. Phrenic nerve stimulation. Sleeping hygiene, very important. Very important sleeping hygiene, like avoid alcohol, sedatives, and opioids. Maintain regular sleep, head elevation during sleep. Now we continue. If you have a problem, you just raise it and we will talk about it as we go on. Now, those are, you see, there are some people that require only sleeping cognitive measures, but there are others that can go up to the the levels of surgical, like the previous topic we have talked about. Now we are talking about the next one, the next one, which is the next one is sleep related hypoventilation. Sleep related hypoventilation. This is during where you are having sufficient ventilation during sleep. So there are types of obesity, hypoventilation, cognitive central hypoventilation, hypoventilation due to neuromuscular, chest wall, and pulmonary diseases. Those people that have problems with the chest due to neuromuscular, then the phrenic nerve is not operating well, and medication and substance induced hypoventilation. Those people that take alcohol before they sleep and some drugs that make their nervous system to slow down. You see, treatment is according to what is happening here. Now, if it is obesity, you will do weight loss. If you have COPD, chronic obstructive pulmonary disease, what do? Optimize medical treatment. Optimize medical treatment like bronchodilators and steroids. Now we go on neuromuscular diseases. These ones are like muscular dystrophies and ALS. I know some people have this in their families. If you have these ones, you respiratory support, disease specific management. You get it. You at least you go to the doctor, they see what they can do. Yeah, they treat the specific one. They will be given drugs that will support your muscular disease, like specific muscular disease, but you'll be given a respiratory support. If it is sedative and opioids, you discontinue these sedatives and opioids. Kyphoscoliosis, chest wall deformities, this may require even surgeries. You get it. Positive airway therapy, bi-level positive airway therapy is important. First line for most, deliver high pressure during inhalation. Like you are giving some things, some machines to help you push more pressure inside so that you can get more air. You get it? We continue. Oxygen therapy is very important to this because now you have a problem with the neuromuscular junctions. And you see, that one requires a help from outside, not the body. Medications like acetazolamide, theophylline, caffeine, or progesterone analog, very important that will help you for this. Phrenic nerve pacing, this is surgical things that are happening in the hospital, especially for congenital central hypoventilation syndrome or high spinal cord injury. If you get a spinal cord injury, you may end up having a phrenic nerve problem. So it needs to be spaced out from what is pressing it not to work well so that your chest movement can be okay. These ones are done in the hospital. Lifestyle, avoid sedatives, alcohol, opioids. Pulmonary rehabilitation, very important. Routine arterial blood gas monitoring, very important. Now let's go to the next one. Sleep work disorders, cardiac rhythm. Cardiac rhythm, you saw this one is a problem by your brain that makes you not to sleep well. So if it is a problem by your brain, what do we do? If it is your problem by your brain, cognitive monitoring is important. Cognitive function is important. Monitoring the and delay sleep wake phase disorders. Monitoring and sleeping at the required time is very important. Sleep patterns is very important. You set onset and wake time are significantly delayed. So what do we do? We there are some things that we do to treat these people. You 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 put a sleep wake pattern. Hmm? In delayed sleep wake disorder, you put a sleep wake pattern. And you can use some drugs like melatonin, 0.5 to 3 milligrams in the evening, 2 to 3 hours before bedtime. You take 2 to 3 hours before bedtime so that they can jack your brain for sleep after 3 hours. Bright light therapy in the morning. When you wake up in the morning, you put on a very bright light so that it can help. You see, it is a rhythm that is disturbed in your head. Advanced sleep-wake disorder. Melatonin is also there, the drug less commonly used low dose, but you use at low dose. You see, this problem that is circadian rhythm is divided into three: delayed sleep-wake disorder, advanced sleep-wake disorder, irregular sleep-wake disorder. Irregular. So the others are like non-24-hour sleep-wake disorder, shift work disorder, and jack disorder. Most of them are treated with melatonin, but 2 hours before you get to sleep. And then the most important thing is you put time. You always put the time that you want. Now, non-rapid sleep-wake disorder, the one that we were talking about yesterday, and some people were, wow, that one happens. Yes, non-rapid sleep-wake disorder, shocks, and when you you are at this, it is characterized by awakening from deep. Lady M, hi, welcome to the platform, Lady M. I'm finishing the last topic of last time about people that have problems in sleeping disorders. And you see, the treatment, all of them are like the same. You treat underlying condition, obstructive sleep apnea, treat it in present. And then GAD, PLMS, treat unsuspecting. Medications, review and adjust sedative drugs. Hey, 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 welcome to the platform. Lady M, welcome. At Lady, at Lady M. I'm seeing at Lady M in the platform. Sorry. Uh, Lady M, welcome, welcome, welcome to the platform, Lady M. We are talking about sleep-wake disorders. Sleep-wake disorders, if you have this problem or specific one, you come out so that we discuss it. Now, treat the answers. If it is period limbic movement, treat suspected problem. You get it? Very important. Go to have sleep hygiene, avoid triggers. Stress management, relaxation is very important. Schedule awakening. Drugs like benzodiazepines, low doses of antidepressant and melatonin is very important in this one. Now we have the other one. I'm moving faster because we have not even started the topic of the day. Nightmare disorders. There are some people who have nightmare disorders. You remember when you have very bad dreams and they occur 20 minutes after you go to sleep. Eh? What can you do to stop these nightmares at night? What can you do? Please like the video and also share. Very important. Some people have these problems and this talk can help them. This is a parasomnia characterized. You see, vivid dreams, and you see when you have vivid dreams, what can you do to stop these bad dreams? A cognitive behavioral therapy, especially for nightmare trauma focused. You do what? Help reframe thoughts and reduce nightmare frequency. You start thinking positively. Your brain always brings whatever you are thinking. So if you are thinking about horror things like witches, like unusual things, you'll dream about them. So you start thinking positively to avoid you dreaming things that are not unnatural. You get it? So if you have a person who has been having nightmares, know that person's brain or that person always thinks about funny things that are not worldly, funny things that are always out of the world. Now, the person, when this person talks and and this person is in the dream, you will find that this person is always always not okay. uh, Something I'm leaving: sleep hygiene and lifestyle maintenance consistent. Now, something I forgot that I was doing here, I continue as we talk about sleep disorders. It's already 5. We talk about sleep disorders. Now, some sleep disorder treatment you have seen, most of them are most of them are treated in the same way. Keep consistent sleep pattern, keep consistent sleep pattern, and we will. Yes, come kuja come. Hizo form za GS kwa songa nikuonyeshe. Yeah. Tuliweka wapi? GS za mkani. Okay, just a minute, guys. Let me work on this faster. When do you nini hizi itakuandikia hapa consultation description service 500, and then we do laboratory investigation. Just a minute, guys. You do for more gram x-ray, does medicine injection, uta calculate dental hiyo provisional diagnosis, dermatitis, fungal dermatitis, hivyo. And then hii ni ya mukame, si ndio? Yeah, you do fungal other services are good. So what you do, you will do like this. Guys, we are finishing about, uh, you are finishing about now. You do two needs, receipts for consultation and for mammogram. And then here utaandika, you'll do fluconazole IV, and you do tuifanye 200 100 ml start, you do at 1100 sawa, times 3, si ndio? Times 3, and then dexamethasone times 4 times 4 uandike hapa at 300, and then oncosi at 1200. Yes, lady F, wait a minute. One ini cream, so ujaze huku one ini times 3 fluconazole, hiyo ni 3300, and then this one utaandika upige rubber stamp. You take the rubber stamp is there, alafu nijazie huku. Ambia mkame tutaitisha hizi kwanza juu kuna limitations, alafu hizi tukiitisha enda ujazo niletee ni confirm. So shikaenda ukishaitisha the other ones we will nijazie huku kwenye sijajaza, sawa, huku alafu niletee. Yes guys, let's continue. That was I had to have that call because of someone. Now we continue, very important. Now sleep hygiene is very important. Keep constant sleep schedules. Avoid caffeine, alcohol, heavy meals, and screen time before bed. Relaxation techniques, stress reduction is very important when you have these problems. Now we are talking about several complications, and you see nightmares. We are now at nightmares. When nightmares comes, that one, the treatment pattern is you help yourself not to be thinking about funny things when you are sleeping. Oh no, daytime. Don't watch horror movies. Don't think about negative issues. You will not have nightmares. Now we go faster. We have the 10th sleeping problem that we have here is rapid movement sleeping disorder. Rapid movement sleeping disorder. Rapid movement is, you saw about rapid movement. Rapid movement, people walk when they are in sleepwalking and talking in sleep. How can you treat these people? People that do sleepwalking. What can we do on people that are doing sleepwalking? You see, this is a very funny condition that comes when people have Parkinson's diseases, dementia with Lewy bodies, and multiple sclerosis system atrophy. System atrophy. So what can we do to help people not to sleepwalk? Pad the bed and surrounding. You see, remove sharp, dangerous object around, because this person can injure himself, herself, or the other person who maybe he's dreaming that he's fighting someone. This person may injure that person. Consider sleeping on a mattress on the floor if severe. You get it? This ensure safety first. Safety is very important. Ensure bed barriers or separate bed for safety. Pharmacological. Clonazepam. Clonazepam is highly effective, but we use always melatonin sometimes. Treat contributing underlying conditions like what we have talked about, those conditions that have are making you having the sleep wake, because sometimes some conditions disturbs your brain. Avoid medication that worsen, like if you use medications like serotonin reuptake inhibitors, you will start having hallucinations, or you will start sleepwalking. So you reduce them. Beta blockers occasionally they cause, those people that use beta blockers for hypertension, they will have this problem. Behavioral strategies: maintain regular sleep, avoid alcohol. We have talked about alcohol every time, and reduce stress and anxiety. Very important. Very, very important. You see, now we go through this other problem that we talked about last time. Those people that like shaking their legs even in even when sleeping. Hmm? People that like shaking their legs even when they are sleeping. This one is called restless leg syndrome. Restless leg syndrome. It is a very funny thing, but people undergo this restless leg syndrome. Restless leg syndrome treatment. Hmm? What is restless leg syndrome treatment? You are always checking your legs every time. We talked about it last time. You see, iron deficiency, you supplement with iron, buy ranferol or iron drugs, or eat ferritin. You can use ferritin in tablets or injection. Oral iron, you can use them. There are some iron drugs that people use when they are undergoing this. There is Those are drugs that you can use. Regular sleep routine is important. Moderate exercise is important. Leg massage, warm baths, stretch is very important. Avoid coffee, avoid caffeine, alcohol, and nicotine before sleeping. Avoid this thing before sleeping. You get it? Now we continue. We want to finish and start. We start the other we start the other pneumatic compression devices, very important. Pneumatic compression devices is very important. Avoid caffeine. Yes, pramipexole, starts slowing augmentation. Pramipexole, it helps in augmentation. And then we have ratigotin. Retigotin, it's a patch, like the nicotine patch. It helps. Uses if oral drugs not tolerating, you can use it. It's like a patch. Yes, sleep wake disorder. Now there is this one that's called substance medication induced sleep disorder. So this one is very direct. If you are using a substance and this substance is causing you not to sleep well, yeah, it's causing you not to sleep well. What do you do? What do you do when you have a problem and this problem is causing you not to sleep well? You avoid that thing. You avoid a substance that is causing you not to sleep well. You see, treatment like caffeine, nicotine, if before bed, and then you are having insomnias. Hey, avoid them. Avoid alcohol. Alcohol is, some people love it, but for me, it's a source of very many things. Stimulants like amphetamine and methylphenidates. Stimulants like amphetamine and methylphenidates causes insomnia. Opioids. Opioids always causes insomnia because they disturb your central sleep processing area, and it causes apnea. Cannabis, rebound insomnia and withdrawals. Marijuana, people that use marijuana, be careful about it. Antidepressants like SSR, serotonin reuptake inhibitors. You see, and they adjust your switch your times to sleep. Beta blockers, they cause nightmares and insomnias. Steroids, corticosteroids, insomnia, use in the day, reduce dosing if possible. Now, antihistamines, avoid chronic use of antihistamine. You get it? Behavioral and supportive intervention is very important. Now, we are kind of like talking several things at the same time, repeatedly. The treatment is just the same when you talk about this treatment, you see, we talk about the same thing. Now, back to the topic of the day. The topic of the day. The topic of the day. We go to the topic of the day. Go to the topic of the day. Go to the topic of the day, which is we go to the topic of the day. The topic of the day today was elimination disorders. Hmm? Elimination disorders. Elimination disorders. And elimination disorders. We are talking about elimination disorders. Now, topic of the day. Elimination disorders. What do you know about elimination? Elimination disorders. What do you know about topic of the day, which is elimination disorders? Let me see this. Okay. Elimination elimination disorders. To eliminate, very important, to eliminate. What do you know about elimination disorders? To remove, to eliminate, to remove, to eliminate. Elimination disorder are these are groups of mental health condition diagnosed in childhood or adolescence that involve inappropriate elimination of urine or feces. Yes? Hiyo imekuja 74 500. Okay, atakuwa na balance ndio alituma zile hakutuma kitu yenye ametuma. So kwanza to share doctors let and say atakosa hadi kumwelezea doctor kuja uende ni cause of illness fungal. Specialist refer antifungals, intravenous and antihistamine. Okay. Okay, now we continue there. continue, elimination disorders are a group of mental health conditions diagnosed in childhood or adolescence that involve the inappropriate elimination of feces or urine. These, these behaviors are not due to medical condition and must occur at a developmental inappropriate age. You see, this must be when you look at a person in elimination disorder having a problem, and the problem is coming at a place that is not having a medical condition but is having this problem. hmm, you will say this person has an elimination disorder. hmm. It's occurring without any it's occurring without any medical condition. You'll say this person has elimination problem, like enuresis, urinary incontinence. Well, if a person is having a problem urinating in bed, we call it enuresis. Enuresis, urinary incontinence. But encopresis, we call it fecal incontinence. Yeah? Definition. Well, you see, repeated voiding of urine in bed or clothes, whether involuntary, mhm, intentionally, after the age of 5 years, developmental. You see, you after 5 years, you still have the problem to wet bed. Mm? You still have the problem to wet bed, and you see, there is no profound medical problem that you have. After examination, you were taken to a doctor, everything is done, and you don't have any profound medical problem. You see, what do we call this? We call it elimination problem. Hmm? Psychologically, a detailed explanation of elimination disorder, including, you see, you should take this person to a doctor to be examined first so that you can say this person has elimination problem when it comes to mental health. Elimination disorders are conditional involving inappropriate elimination or urine or feces, usually diagnosed in children or adolescents. In children or adolescents, where elimination is not due to a medical condition, substance use, or other mental disorders. The behavior is developmental inappropriate and can cause distress, impairment in social, academic, or functional areas. This one, we call it elimination disorder. We've talked about what is elimination disorder. Elimination disorder is how what you remove from your body, and whatever we remove from our bodies is feces and urine. You see this, feces and urine. So at the age after 5 years, you have these problems that I've talked about and can cause a problem or distress, impairment in social, academic, or functional area. We call it elimination disorder. Hmm? Now, we have two problems when it comes to elimination disorder. We have enuresis and encopresis. Enuresis is about urine, encopresis is about feces. Now, repeated voiding of urine in bed and clothes for after 5 years of age or equal to 5 years of age. Even adults we see sometimes they have this problem. We call it enuresis. And repeated passage of feces in an appropriate places. 4 years. After 4 years or more equal to 4 years, a period of 4 years, we call it encopresis. Now, enuresis, urinary incontinence. Subtypes. We have types of enuresis, those people that just pass urine. We have subtypes. What are these subtypes that we are talking about? We are talking about nocturnal enuresis at night, bedwetting during sleep. We have diurnal enuresis, daytime wetting, and combined. There are three. What can be the cause? You see, what can be the cause? You are sleeping and sometimes you're just wetting the bed. Hmm? And at times you are daytime, it's daytime and you are wetting the bed. What is the problem? One, genetic predisposition is important here, family history, because of neurotransmitters, carrying on neurotransmitters to the other parent or generation. Delayed bladder maturation. Some bladders of some people are delayed to mature. They are still having problems. Small functional bladder capacity. Your capacity of your bladder functionally is small. Excessive urine production at night. You sleep and your body produces a lot of urine at night. You see, that is a very big problem. Deep sleep arousal dysfunction. Deep sleep arousal dysfunction. When you are sleeping so deep and you sometimes start to dream that you are urinating and you urinate in deep sleep. There are stressors, my friend, stress, divorce, school change, abuse. Hmm? These are things that will make you have these problems. Hmm? So they must be looked at. Inappropriate toilet training in children, very important. You see, very important. Repeated urination into bed clothing, involuntary, hmm, at least twice per week for 3 consecutive months or cause distress. This one, we can say this person has a diuresis. Chronological or developmental age of or 5 or more than. These are criteria that we look at and we see this person has this problem. And then we have not attributable to a medical condition. You don't have a UTI, you are not diabetic, you don't have all the things that are above, and you are bedwetting. You see, that is a problem. Okay, we continue with some investigations that you can do when a person has these problems. These investigations are like urinary and culture, urine and culture checkups. You do urinalysis when it comes to urine and culture. Urinalysis is urine analysis where you check the leukocytes, the proteins in urine. You check specific things like the pH of the urine to guide you to know if there is a problem with this person. You get it? Voiding diary. How you are removing the urine, the program, how you are removing the urine. Blood ultrasound. Do an ultrasound to see if everything is okay. Now we have differential diagnosis like urinary tract infections. People can have UTIs and then they think they have your child has this. Diabetes mellitus or insipidus. When you are having this, you know a person urinates so much. Neurological bladder problems when the muscles cannot hold it anymore. Seizures, nocturnal, when you have seizures and people think you have urinated on the bed. Now, treatment for these mostly is cognitive behavioral therapy, very important. Bedwetting alarms, most effects long term. Pharmacological, desmopressine, reduce night urine production. Yes, desmopressine is a drug that we use so that at night when you are urinating, it reduces you from urinating. You get it? Desmopressine. And then there's imipramine, a tricyclic antidepressant used in caution. This one you should use with caution. Hmm? Now, we have talked about enuresis. You've seen how it is when you are having these problems of enuresis. Now we talk about the other thing, which is encopresis. Encopresis. Encopresis is a physis. With this one, they have subtypes or two: without constipation and overflow of incontinence, and with constipation, non-retained usual behavior, non-retained unusual usual behavioral. Incontinence is where you have a problem to remove, and then constipation is a place is where you are constipated. You understand how what constipation is? Is where you have hard stool and you have a problem to pass the stool. That is what people know about constipation. Now, the causes may be the causes in constipation. You know, constipation is a funny thing, and when we do constipation, it may be brought by other problems. Use of antibiotics sometimes can make you to have constipation. Some diseases might make you to have constipation. Dehydration can make you to have constipation. So when it comes to encopresis, fecal incontinence, that is, you see, you have a problem when it comes to passing stool, and it can pass out everywhere, just like enuresis, bedwetting, because we are talking about two things, enuresis and incontinence. Hmm? You will see some problems like chronic constipation without stool retention. Hmm? Fear of defecation, because when you go to the loo, some people have hemorrhoids and it is very painful. So it may pass wherever you are. Fear of defecation and psychosocial stress like neglect, family conflict, stress always comes in when it comes to elimination of some products in your body. And some people in some up countries and some places, some informal sectors, they may have uh, no toilets. So it makes them keep it stool for long in the stomach, which is not okay. You keep stool for long in the stomach, which is not okay. And then you have a problem when it comes to voiding. Now, it is not proper. When you feel like going to the loo, you hold on. It will come with some problems. And these are the problems I'm talking about, like encopresis, lack of toilet training for kids, neurological or developmental disorders are a problem. Now, when we talk about encopresis disorder, we have some things that we need to look at so that we know this kid or this person has encopresis. What do we look at? It occurs at least once a month for 3 months. Once a month for 3 months. And then you look at the age. The age is at least 4 years or above, not due to any medical condition. But there are some conditions that people confuse them with encopresis, like Hirschsprung diseases, spinal bifida, irritable bowel syndrome, and gastrointestinal malformations. Those are not encopresis. They are conditions, and this because they are conditions secondary to this, they need to be. Oh, yeah. Sorry. They need to be sorted. Investigations for this before you go and say that your child or your person has encopresis. You have to do abdominal X-ray. Check. Check with an X-ray to see if the stomach has a problem. You check if the stomach has a problem, and the other thing is you rule out neurological and developmental problems. Rule out neurological or developmental project problems. Sorry. Treatment here. Treatment always is laxatives to make the stool at least soft laxatives, maintenance of therapy to prevent constipation, high fiber diet is very important. High fiber diet is very important. It will help clearance. Behavioral training to go to the loop. Complications, we have psychological complications. Hmm? Bullying, family stress, chronic infections, academic problems due to poor performance, concentration, and anxiety. Yeah? And then we have children often feel ashamed and anxious, maybe withdrawn from social interaction, risk of depression, and behavioral issues. Yet, if are not addressed early, this may be a problem. We need multidisciplinary team when it comes to these children. Pediatrician, child psychologist, psychiatrist, family therapy, very important. School support is important, very important. You see that? Very important. Now, we go to the next topic of the day, elimination. I decided to come out with it today because I saw it's not a big topic, but if someone has a question, uh, you can ask. You type any question wherever you are, and we see what we can do about that. We have dealt with so many complications that we have dealt with so many complications, and people are learning so many things. That's why I decided to talk to people about these issues. It is not okay when you have a problem and you can help and you are keeping quiet. It is not okay. Now, we had another topic that we're talking about. The topic is called feeding disorders. Feeding disorders. You know, uh, a minute, some people have problems when it comes to food. Some people have problems when it comes to food, and you will not know these people have problems of eating. You'll just say someone is gluttonous. That one we know she is gluttonous. He likes eating a lot. But you've never sorted out if this person has a problem in eating. If this person has a problem in eating psychologically, it's very important to find out if this person has a problem psychologically in eating so that you may help this person. See, feeding and eating disorders are psychiatric conditions marked by abnormal eating behaviors and disturbances in eating related thoughts and emotions. Hmm? I repeat, feeding and eating disorders are psychiatric conditions marked by abnormal eating behaviors and disturbances in eating related thoughts and emotions. Significantly impaired physical health, social functioning, or both. These disorders are everywhere. Mm. You see, there are several core disorders of eating disorders. There are several, like anorexia nervosa, mm, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, and then we have something called the PICA. PICA, P-I-C-A, PICA, P-I-C-A. And then we have rumination disorder. Those are some of the problems when it comes to eating disorder. You get it? when it comes to eating disorders. Now, as we have said, like eating disorder, abnormal eating behaviors and disturbances in eating related thoughts and emotions, significantly impairing physical health, social function, or both. Hmm? Let's get down to each of them, like anorexia nervosa. What is anorexia nervosa? What is anorexia nervosa? Anorexia nervosa, an eating disorder characterized by restriction of intake of energy intake leading to significantly low body weight. Some people will eat, but they will not have the body. You are eating, but your body is still e- wait. You are eating, but your body is still down. You should ask yourself what is the problem. Intense fear of gain or becoming fat. This is a problem to some people, mostly ladies. Distorted body image or denial of the seriousness of low body weight. Hmm? You see, persistent restriction of energy intake. Hmm. 10 in male to female, it is 10 to 1. Commonly between 14 to 10 ages, 14 to 18, sorry, 14 to 18 ages of uh, of 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 of, of females. Hmm? And even young boys, 14 to 18. The high risk in athletes, models, perfectionist individuals, those people that have that personality, being perfectionists, they have small bodies. Hmm? Restriction type. There are some types like restriction types, weight loss achieved through dieting, fasting, or excessive exercise. Binge eating, purging type. Individual regularly engages in binge eating or purging. Vomiting, laxatives, enemas, or diuretics. You are chronically using enemas and diuretics, and you are not having the problem to 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 use those products. Hmm? That is up binge eating. Restrictive type, weight loss achieved through dieting, fasting, and yes, and the others. Now we have some causes like genetic predisposition, neurochemical imbalance like serotonin and dopamine dysregulation, hormonal changes, e.g., low leptin and hypogonadism, mm, psychological, low self-esteem, perfectionism, obsessive compulsive traits, need for control. Very important. Now we will finish the first topic, and then this topic I think we will continue with it tomorrow. I think we will continue. If we finish this, we'll continue with it tomorrow because today I think there is a lot of work that I'm needed to do. Sorry for that. Now we go to clinical features. Clinical features: significant weight loss, amenorrhea, bradycardia, slow heart rate is bradycardia. And then we have hypotension, cold tolerance, dry skin, lanugo hair, constipation, delayed puberty, hypothermia, psychological, distort body image, intention of being fat, And investigations, we always do an complete blood counts for anemia. We do electrolyte imbalances for kidney functions, liver function tests, and hormonal balances. And then we have differential diagnosis. We will see about them. Other problems that may look like this one, like hyperthyroidism, body deformic disorders, GI disorders like celiac disease. And then complications we'll have in bulimia nervosa. You don't want to eat well. You'll cardiac arrhythmias, infertility, renal failures, gastrointestinal dysmotilities, and sudden death. Psychological, suicidal ideation, depression, and anxiety. So, guys, I think we finished the topic today. We could not cover two topics. We will continue with this tomorrow. Have a good day and be blessed. Yeah.